And you can see that here. This is the airway epithelium, and you would expect this to be the pseudostratified ciliate epithelium normally, but here you see an awful lot of goblet cells. Thousands of goblet cells, all that mucus. Okay, any questions at this point? All right, so you got some chronic inflammation in the airways. That causes the airways to become hyperreactive. But there are some other consequences of the result of the chronicity of the inflammation. The chronicity of the inflammation does cause a lot of damage, a lot of architectural damage to the airways over time. And as a result, you see changes in the structure of the asthmatic's airway compared to someone with a normal airway. Overall, all that inflammation causes the airway wall to become chronically thick. A lot of the structural changes also contribute to an increase in the thickness of the airway. So typically, when you compare the airways of a normal patient to that of an asthmatic, the airways of an asthmatic are a lot thicker. Also, a lot of inflammation causes a lot of desquamation of the epithelium of the airway wall. A lot of asthmatics will cough that up, cough a lot of mucus, a lot of this debris up. The epithelium tends to kind of curl itself up in these long filamentous structures. They're called Kirschmann spirals. You can see it here. Here's a sample of sputum from an asthmatic. And you can see quite a few squamous cells in this section. These squamous cells are metaplastic squamous cells. Their airways are very irritated. That pseudostratified epithelium has changed into a squamous type epithelium. You can see the squames here being coughed up. You can, of course, see a lot of inflammation in the background. A lot of neutrophils here, I see. Okay, a lot of macrophages over here. And there are even a few eosinophils you can clearly see in the sputum. Amongst all that, you see these red staining, stringy structures here. Those are called Kirschmann spirals. It's actually desquamated epithelium. It kind of rolls up into a little filament like this, and they cough it up. And so if you see this term Kirschmann spirals, that's generally something you associate with asthma. All right, let's take a look at some of the changes in the architecture of the airway wall of the asthmatic. And I said before, all of that chronic inflammation is going to have an effect on the airway. It's going to cause the airway to become thickened, and the lumen will become a little narrow over time as a result. Let's take a look. Here's a normal airway. It's a section through a bronchiole, and you can see the lumen. There's the wall. Wall is generally of a sturdy construction. It's very difficult to collapse that airway wall. You got a nice patent lumen. There's not much mucus in there. The only mucus you're going to find is a thin layer covering that pseudostratified ciliate epithelium. In an asthmatic, the airways are chronically inflamed. And so when you take a look at the airway of an asthmatic, you can see the airway wall itself is very thick. That's partly due to edema, but it's also partly due to structural changes that occur over time. Also, the inflammation fills the lumen with mucus. And so asthmatics tend to have that cough that's productive of some mucus. This is what they're coughing up, a lot of this extra mucus. Okay? Let's take a look at what happens to the airway wall architecture of the asthmatic. So we have a depiction here of a normal airway, and again, a depiction of the architecture of the airway of an asthmatic. You've got the lumen over here. There's the layering of the airway. You've got the mucosa here, submucosa here, and of course you've got some structural cartilage down here. Take a look at the mucosa. First layer is the epithelium, and it's covered by a thin layer of mucus that's normal. It sits on top of an epithelium, which is a pseudostratified ciliate epithelium, and you know that the epithelium and the mucus collectively are trying to trap any kind of debris that are inhaled, and they can move all that debris up to the oropharynx. The epithelium sits on a basement membrane. All normal. Below that you have the lamina propria. Lamina propria is the first vascularized layer. And you do have some inflammatory cells in the lamina propria. Those inflammatory cells are sentinel cells. They're just there, they're not basically not doing anything unless some bacterium tries to invade, then they'll be there to deal with it. Then you have this smooth muscle layer. That's the smooth muscle layer that's controlling caliber of the airway. That's the muscularis mucosa. It's a relatively thin layer of smooth muscle. Okay? Collectively, that's the mucosa. Below that, you have the submucosal glands. They're producing, again, a lot of secretions dumped on the surface of the lumen here. Generally, that will contribute to the fluidity of that mucus. The mucus is easy to move, easy to cough up in a normal individual. Who's basically going to use that just to trap the breath. Then, of course, you got the structural cartilage down here. Okay? That's the typical thickness of the airway. Again, you see it here. Everything looks good there. Down here we have the architecture of the asthmatic airway. Very different. The lungs here. And we have the mucosa here. First thing you notice, there's an awful lot of mucus there. And again, the mucus is being produced at an accelerated rate because these airways are chronically inflamed. That'll trigger the production of mucus. Within the mucus, you do have a lot of inflammatory cells. There's the epithelium. You expect the epithelium is going to be pseudostratified ciliated. In parts it might be, but there's also a lot of goblet cells. Obviously, goblet cell hyperplasia, goblet cell metaplasia. In response to this inflammation, they're responsible for producing all that extra mucus. The basement membrane they sit on is thickened. That's due to chronic inflammation. The lamina propria, again, also thickened, is filled with inflammatory cells. Lots of different inflammatory cells. You see lymphocytes, macrophages, neutrophils, but you especially take note of this one, eosinophil. Eosinophil is a white blood cell you see infiltrating the airways. In asthma, you typically don't see it in other types of pulmonary diseases. Lots of congestion, extra thick lamina propria. Smooth muscle layer also thickened, again because of the chronicity of disease. And then you have lots of submucosal glands that are abundant, again because of the inflammation. Altogether, these different changes, the architectural changes of chronicity of disease and the edema cause the wall to become much thicker than normal, and so you have this increase in thickness. Generally, that's going to occur at the expense of the luminal diameter. And as a result, even when a person is not having an asthmatic attack, the luminal diameter is somewhat reduced, and so they're actually, even though we classify asthma as an acute obstructive disease, because of the quick onset of symptoms, there is a component of chronic obstructive as well, simply because there's a reduction in the luminal diameter. So we do classify this as an acute obstructive disease, but just understand there's an element of obstructive, chronic obstructive component to it. Any questions on that? Okay, so how do we treat this condition? Most of the time, when a person is not having an asthmatic attack, they're fine. There may be some irregularities. They may have a chronic cough. Again, that's because your airways are irritated. Sometimes they'll cough up maybe with mucus. If you take a radiograph of someone with asthma, sometimes you will see evidence of resorption atelectasis, usually affecting segments of the lung. The segments of the lung collapse, kind of making it look like an opaque disc in the lung. And so sometimes that's called discoid atelectasis. Again, you see that as a result of that, this mucus plugging up the airways. The big problem, of course, is when someone does have an asthmatic attack. The airway is clamping down. They can't breathe. They may be able to inhale, but exhaling takes an inordinate amount of effort. Their lungs become hyperinflated because the air gets trapped in there. We want to, of course, relax the airways as quickly as possible so that they can breathe again. We do this using a beta-adrenergic agonist. You're probably all familiar with the one we use. It's called albuterol. Albuterol is the typical beta-2 adrenergic agonist we use. The beta-2 adrenergic agonist relaxes the smooth muscle in the airways, and that allows the airways to open up, and of course it tends to abort the spasm that the patient is having. Okay? There are other medications we use prophylactically to prevent an asthmatic attack, but albuterol is the drug we use to abort an asthmatic attack. Drugs that we can use for prophylaxis include things like steroids. Steroids, of course, are immunosuppressants. The person inhales the steroid, gets distributed in their airways, and kind of reduce that amount of chronic inflammation. It makes the airways less irritable. There are also some other prophylactic agents we can use depending upon whether the person has extrinsic or intrinsic asthma. Any questions on that? Let's talk a little bit about the pathogenesis and workup. So I mentioned the main problem with both intrinsic and extrinsic asthma, the patients have this hyperreactive airway. Okay? They just overreact to anything that can cause bronchoconstriction. In fact, you can establish in part the diagnosis of asthma by testing the reactivity of the airway. Very often we'll use some sort of provocative agent, a bronchoconstrictor, and just see to what degree the airways will constrict. Now, any normal airway in response to a bronchoconstrictor is going to constrict, but there's a certain proportion in which it should constrict. In the airway of an asthmatic, you challenge the airway of the bronchoconstrictor, they go into a spasm. They don't just constrict in proportion, they just go into a spasm. Okay, again, the morphology. Lungs are distended during an asthmatic attack. They can't really exhale the air. There may be some degree of this segmental atelectasis, this discoid atelectasis. They're coughing up sputum containing Kirschmann spirals. Okay? And again, the airway infiltrates characterized by numerous types of inflammatory spells, but especially the eosinophil. The eosinophil is almost unique to the asthma inflammatory infiltrate. Okay, any questions on that? Okay, so that's an example of an acute obstructive lung disease. Acute obstructive lung disease is characterized by an abrupt but reversible decline in the FEV1. If someone has asthma, they're going to have a more or less normal FEV1. Most of the time when they have an asthmatic attack, there's going to be a very abrupt drop in the FEV1, and that could be very quickly reversed either by its own resolution or by administering albuterol. Then we have the chronic obstructive pulmonary diseases. These are collectively referred to as the COPDs, or COPD. Okay, one example of chronic obstructive pulmonary disease is emphysema. The chronic obstructive pulmonary diseases are characterized by an insidious reduction in the FE1 that is not reversible. Meaning that once a person develops the obstruction to airflow, you can't reverse that. But it does take quite some time for the obstruction to develop. It doesn't happen like that. It can take years to develop the obstruction. So we describe that as an insidious development. Insidious, kind of very slow, almost unnoticeable at first. But once it develops, it's not reversible. So that's why they're called chronic obstructive pulmonary diseases. Now, two very common chronic obstructive pulmonary diseases are emphysema and chronic bronchitis. And usually when someone has emphysema, they have chronic bronchitis. When they have chronic bronchitis, they'll have emphysema. The reason for that is both of those diseases typically have the same etiology, cigarette smoking. Cigarette smoking is responsible for the majority of cases of emphysema and the majority of cases of chronic bronchitis. And so typically when one has one disease, they'll have the other as well. Okay, let's talk a little bit about the problem with emphysema. Emphysema is a condition where the airways lose their structural integrity. Normally the airway is a very sturdy structure, they remain patent during inhalation, they remain patent during exhalation. However, typically as a result of cigarette smoking, the structural integrity of the airway is lost and the airway becomes very flimsy. And as a result, people can inhale, but when they try to exhale, the airways collapse on them. And again, the airway gets trapped in the lungs become hyperinflated. Now, this loss of structural integrity of the airway is actually due to an increase in protease activity. There's a protease called elastase. And in the lungs of people with emphysema, this elastase activity increases and it breaks down the proteaceous structure of the airway. The airway loses its structural integrity, it becomes very flimsy, and again, it's very difficult to keep the airways patent during exhalation. Most cases of emphysema are caused by cigarette smoking, and that's because cigarette smoke increases the activity of this protease called elastase, and that causes the degradation of the airway wall architecture, resulting in those flimsy airways. Now, as the structural integrity of the airways are lost, people have difficulty exhaling the air. They can inhale, try to exhale, it just won't come out of their lungs, and the air builds up in the lungs. Eventually, the air pressure in the lungs becomes very high. This causes the alveoli to rupture. And as a result, people with emphysema start losing alveoli. They lose alveoli, they start losing gas diffusion capacity. They start losing surface area through which gases can diffuse. And eventually, it becomes very difficult for them to exchange gases, to respirate. In addition, every time they lose an alveolus, they lose the pulmonary capillary network that is encased in the wall of the alveolus. And that is the capillary network through which the right side of the heart has to pump blood to the left side of the heart. Now, if you take all of those pulmonary capillaries, you add up their cross-sectional area, you get a rather large cross-sectional area through which the right side of the heart is going to pump blood to the left. Very easy for it. Doesn't require much muscle power to do that. But you start losing those alveoli, you start losing those pulmonary capillaries, you start losing the total cross-sectional area. And it gets very narrow. And it's very difficult for the right side of the heart to pump blood through that narrow airway. The resistance to blood flow increases. You have to strain on the right side of the heart. And the right side of the heart starts to hypertrophy. And you know we call that what? When the right side of the heart becomes diseased as a result of pulmonary disease, or pulmonale, it would be acute or chronic. It hypertrophies. Chronic or pulmonale. Hepatic question.
Why exactly is the capillary network being taken out? Is it because of the activity with the proteolactate too?
Well, if you lose an alveolus,
yes,
the walls of the alveolus have that pulmonary capillary. So if we look at the lung, you can see it's loaded with alveoli.
yes,
Each wall has a network of pulmonary capillaries. So if you lose an alveolus, you lose the pulmonary capillaries in that wall. And you can just imagine, if you sum all of the cross-sectional area of all those capillaries, it's quite a significant cross-sectional area. You start losing alveoli, you lose the cross-sectional area. Now that puts a load on the right side. Dominique?
Yeah, with cor pulmonale, acute versus chronic, in both situations there is hypertrophy, but with one it's no failure, with the other one it is failure.
The difference between acute and chronic is the condition of the right ventricle at the time of failure.
At the time
Both
of
will
failure.
fail.
Okay.
Acute, no time to hypertrophy. Chronic, time to hypertrophy.
Okay.
Okay, so we understand the basic problem with emphysema. We're losing these alveoli. And that's due to air being entrapped in the lung caused by flimsy airways. All right, let's take a look at that. So here's that section through healthy lung. There's the pleural cavity out here. Of course, the lung is here. This is the visceral pleura. You keep hearing about that visceral pleura. There it is. It's just a section there of some fibrous tissue covered by a mesothelium. Okay. Below that, you can see the lung parenchyma, very healthy. There's a terminal bronchial. It's loaded with alveoli, and as I said before, each one of these alveoli has lots of pulmonary capillaries. You have lots of surface area to diffuse gases, so respiration is gonna occur very easily, gas diffusion capacity very high, easy to move air in and out of this lung. These airways become flimsy, they'll trap air. They won't allow air to exit in the exhalation phase. So air is gonna build up in this lung, it's gonna over-distend these alveoli, they're gonna rupture, and you're gonna lose them. And so people with emphysema have a conspicuous decrease in alveolar density in their lungs. This is normal lung. This is what emphysema looks like. And pleural cavity, visceral pleura, here's the lung parenchyma. Now you can see some alveoli, but look at these areas here. Here are areas completely devoid of alveoli whatsoever. Looks like they have spaces there. All the alveoli in those areas are ruptured, and their spaces are consolidated. We've got nothing but these big spaces here, no alveoli, no pulmonary capillaries in that area either. Okay, so that's going to have two consequences. One, gas diffusion capacity, suboptimal. Resistance to blood flow through the lungs, very high. Puts a load on right ventricle. Now remember, that happens insidiously. So the right ventricle is going to be presented with a greater afterload, very slowly building up. That's going to cause chronic pulmonality. Let's take a look at the gross appearance of normal lung and emphysematous lung. So there's a section through normal lung. Again, you see the visceral pleura there. There's the lung, cut surface, granose surface filled with alveoli. Okay, looks pretty good. All right, and if that's normal, well, here is what emphysema looks like. Okay, looking at the apex of the lung, visceral pleura here, cut surface. You can see you've got some normal lung tissue here, but most of this lung is remarkable for these very large holes. These are areas where the alveoli have ruptured and the spaces have consolidated. Now, most of the time, when emphysema is caused by cigarette smoking, most of the emphysematous change will affect the apex of the lung. There are other causes of emphysema, but the distribution of emphysematous change is different. There are some genetic causes of emphysema. Typically, with the genetic causes of emphysema, you'll see most of the changes in the bases of the lung. But with cigarette smoking, most of the emphysema you notice is in the apex of the lung. So cigarette smoking, apex of the lung. That's where most of the emphysematous change occurs. All right, so a lot of loss of lung parenchyma. Again, strictly speaking, this emphysema isn't too bad, but some cases, a lot of this lung parenchyma is lost. And quite frankly, the only thing holding air in the lung would be the visceral pleura here. The visceral pleura is subjected to a lot of pressure. Now, visceral pleura is made out of connective tissue. So connective tissue doesn't stretch, but it does remodel. And sometimes when it's subjected to a lot of pressure, it eventually, over the course of months to years, will kind of remodel itself and kind of bulge outward, forming what we call bullae. Here's what it looks like. This is an example of the bullae formed in the lung as a result of emphysema. Again, apex base of the lungs here. Hilar regions, okay. Base of the lungs look good. But look at the apices. You've got these weird-looking, big, cyst-like structures. Those are the bullae. Those are nothing more than parts of the visceral pleura bulging outward. Why? Because they have been subjected to a lot of pressure. They remodel. They don't stretch. They remodel. And they adopt these very grotesque distortions in the visceral pleura. This pleura down here is nice and shiny and flat inherent to the surface of the lung. Over here, it's kind of bulging out. Okay. When someone develops this type of emphysema, we call it bullous emphysema. You heard of bullous emphysema? Maybe some of you. It's a more severe form of emphysema. That's what it looks like. That's why we call it bullous emphysema. And it's a remodeling of the visceral pleura because of the high pressure. Now, these bullae, they sometimes rupture. And what would you think would happen if the bullae ruptured? I couldn't hear you.
A possible pneumothorax?
A pneumothorax, yeah. So air is going to come out of that lung, it's going to enter the pleural cavity. And the pressure in the pleural cavity will equalize with the pressure in the atmosphere. Now you remember that in order to expand the lungs, there has to be a vacuum in the thorax compared to the atmosphere. That's what keeps your lungs expanded. If you introduce air into the thorax, you equalize the pressure in the thorax with the atmosphere, and that causes the lung to collapse, and you get what we call a pneumothorax. And this is what it looks like. Okay, so here's a chest radiograph of someone with a pneumothorax on the right side. So this is a nice digital image. You can see the trachea. There's the cardiac silhouette, and of course you can see the diaphragms here. Taking a look at the left lung. Left lung looks okay. You can see vascular markings. The hilar region looks good. The vascular markings tell you there's lung there. And you can't miss the lung when you got those vascular markings. Over on the right side, you notice, well, I guess there's some vascular markings up here, but do you see any vascular markings anywhere over here? None. That's because there's no lung here. Where's the lung? You see the outline of the lung here. It's pulled away from the wall. This lung is collapsed. It's recoiled under its own elastic structure. Okay? And all of this part of the thorax is now filled with air. This is an example of a pneumothorax. This pressure is equal to the atmospheric pressure. Over here you still have a vacuum that keeps this lung expanding. And as a result of being more pressure over here, everything is being pushed over to the left side. And you can see the whole mediastinum is starting to shift over to the left side. Look at that. Look at the whole mediastinum shift over there to the left. Even the trachea is ever so slightly deviated to the left side. Not too bad, but there's definitely a tracheal deviation. Usually the trachea is midline or slightly to the right. This trachea is slightly to the left. Okay, so there's some degree of left tracheal deviation here. Again, that's because of the pneumothorax. Here, the atmospheric pressure here is higher than the subatmospheric pressure over here. Everything's getting pushed over. High pressure is pushing it over, the vacuum over here is looking to pull it. So you get some sort of deviation. A person like this probably feel a little discomfort suddenly when one of those bullae rupture. They feel some pain. They'll probably start coughing. And of course, they'll have some degree of dyspnea. Any questions here? As I mentioned before, the primary cause of this is cigarette smoking. Cigarette smoking causes an increase in elastase activity in the lung. That degrades the structural integrity of the airway. So you can inhale, but try to exhale, the flimsy airways collapse. Then the air gets trapped in the lung, the lungs become hyperinflated. Why is there an increase in elastase activity as a result of cigarette smoking? Well, there are actually two mechanisms whereby cigarette smoking can increase this elastase activity, causing a degradation of the proteinaceous structure of the airways. Let's take a look at it. Okay? One mechanism whereby cigarette smoking can increase elastase activity is to stimulate the white blood cells to produce more. There's an increase in elastase production, neutrophils and macrophages. The elastase actually comes from the neutrophils and the macrophages. They get irritated by the cigarette smoke, they make more elastase. The elastase damages the proteinaceous tissue in the airways, making them flimsy, they collapse, that results in emphysema. So an increase in the production of elastase is one mechanism whereby elastase activity increases. But there's another mechanism in which cigarette smoking increases this elastase activity. Cigarette smoking also destroys a protein that's supposed to counter-regulate elastase. It's called alpha-1 antitrypsin. It's an anti-elastase. It inhibits elastase. So you typically have this protein that's constantly inhibiting elastase, preventing this enzyme from being overactive. Cigarette smoke destroys this anti-elastase. And when you destroy an inhibitor of elastase, you disinhibit the elastase. And now the elastase activity increases. So now you have more elastase, and it even has more activity because it's not inhibited. Again, this will contribute to elastic damage, and you get emphysema. This is typically what happens with cigarette smokers. Cigarette smoking increases the elastase activity. Now, I mentioned before that when someone develops emphysema as a result of cigarette smoking, most of the emphysematous change is where in the lung? The apex of the lung. But there are other causes of emphysema, albeit much less common, but there are other causes of emphysema. Sometimes there are genetic reasons a person will develop emphysema. One genetic disease might involve this alpha-1 antitrypsin, this anti-elastase. Some people have an alpha-1 antitrypsin deficiency. They're not making that inhibitor. And if they're not making that inhibitor, again, they have an increased elastase activity. And that results in emphysema. Typically, the distribution of that emphysematous change is different. When someone has a genetic alpha-1 antitrypsin deficiency, the emphysematous change is concentrated in the bases of the lungs instead of the apex. There are a few other differences. People who develop emphysema as a result of cigarette smoking, they develop emphysema maybe in their 50s and their 60s. People with a genetic disorder, they develop emphysema in their 30s, much younger age. And that's typical of a genetic disease. You typically develop disease very earlier on if it's genetically based, rather than developing something that's more as a result of behavior or environment acquired. Okay? So, cigarette smoking, apex, 50s and 60s. Genetic derangement, much earlier, 30s, bases. I expect you're not going to see too many people with an alpha-1 antitrypsin deficiency and emphysema of the bases. So most of the time you're going to just see apical disease caused by cigarette smoking. Okay, so we said a couple of times that the lungs become hyperinflated. You can inhale, but you can't exhale. Let's take a look at this. Here's two radiographs comparing a chest, thorax within normal limits, and we're comparing it to someone with emphysema. A couple of things to notice. Looking at the chest radiograph within normal limits. First thing, you look at the thoracic morphology, you kind of see there's a slightly inverted V morphology, at least on chest radiograph. That's normal. Cardiac silhouette looks good, normal. Shape, size looks normal. The hemidiaphragms look normal. They have this concave morphology. The domes of the diaphragms pucker upward like this. That's the morphology of a diaphragm that's pulling down on the lungs. Diaphragm pulls down the lungs, it kind of puckers like this as it creates a vacuum in the thorax to expand the lungs. And so you get that curvature. That's nice curvature. Okay? Everything looks good here. The lungs are not hyperinflated. They are normal. Over here, looks like we've got an elderly woman with emphysema. Notice the morphology of the thorax. We talked about that in physiology. It looks like a barrel. These people are described as being barrel-chested. Now, barrel-chested specifically refers to a change in dimensions of the thorax. Normally, the transverse diameter is greater than the AP diameter. But people with emphysema, they have hyperinflated lungs, and that causes the whole chest to bulge outward. And so you get a greater AP diameter compared to the transverse diameter. That's actually a definition of barrel-chested. But you can appreciate the morphology of that chest. Looks like a barrel. Right? So his lungs are hyperinflated. The cardiac silhouette, smaller than what you'd expect for normal. That's because the lungs are compressing the cardiac silhouette. Okay, this heart is actually slightly tamponaded by the hyperinflated lungs. look at the diaphragms. You notice the domes of the diaphragms are flat. They're not puckered. They don't have that nice curvature like they're supposed to. Okay? This is the morphology of a diaphragm that's being pushed down by lungs. Lungs are hyperinflated. They're pushing down on the diaphragm. The diaphragm is supposed to pull down on the lungs. That's what makes them pucker. But this diaphragm is being pushed down by the lungs. So the dome of the diaphragm is going to be collapsed. It's going to be flat. That's flattening the diaphragms. Another finding consistent with hyperinflation of the lungs. Okay. Looking at a radiograph, left lateral, again, you can appreciate there are lots of changes here. Okay, sternum, the heart, the vertebral column. Okay, you can see one hemidiaphragm here, that's the left hemidiaphragm. You can see the right hemidiaphragm right there. Again, nice curvature. Normal AP diameter, that's emphysema. Increased AP diameter, and the diaphragms don't get much flatter than that. And again, you can appreciate the thoracic morphology. This is barrel chest. Again, everything you see here is due to hyperinflation of the lungs. Okay. Remind you the definition of barrel chested. It really isn't related directly to morphology. Definition is actually related to the measurement of diameters. So here we have sections through the thorax. Again, the thorax, normally the AP diameter is less than the transverse diameter. Emphysema, the lungs are so hyperinflated, the chest remodels and it bulges outwards. When you see it on a patient with advanced emphysema, it is quite noticeable. Okay? The AP diameter exceeds the transverse diameter. That's barrel chest. Okay, any questions on this? All right, why don't we take a break here, then we're going to finish up with emphysema. We're going to talk about loop bloater.